Great. Can you all hear me? Michael, just give me a thumbs up if you can. Excellent. So again, personalized medicine and the treatment of SADS conditions. I'm going to talk about drugs, denervation, devices, and more. And I'd like to dedicate my talk, although it's probably not good enough, but to my two wonderful friends, the Michaels, the late, great Michael Vincent, and the continuing to be great Dr. Michael Ackerman. Thank you, everybody, for coming. So these are inherited arrhythmias or genetic disease. I think you guys know that. You're all here as families. I'm going to focus most of my efforts today on CPVT, long QT syndrome, and Brugada syndrome. Let's start with CPVT, or catecholaminergic, this is a mouthful, catecholaminergic polymorphic ventricular tachycardia. This is a potentially lethal genetic arrhythmia syndrome that's characterized by you're on. It's characterized by exercise-induced arrhythmias and may represent as much as 15% of autopsy negative young sudden death. This is a classic electrocardiogram in a patient of mine with CPVT, and just look down at the bottom. This is ventricular tachycardia, and it's what we call bidirectional ventricular tachycardia. So they go in different directions. Let's look at that a little bit more closely. Bidirectional ventricular tachycardia is a 180-degree QRS rotation variation. Now, this arrhythmia, bidirectional VT or BVT, may actually be fairly well tolerated in this population because generally these are young patients with normal hearts. But unfortunately, this BVT can degenerate into ventricular fibrillation, which is not well tolerated. Years ago, we looked at children, 226 children with CPVT, and this was really from the PACES group, and we found that their events were characterized by occurring during emotion or exertion. This is a disease with early onset. Now, I don't know about its onset in the tiny young children, but the average age of onset or presentation is between 6 and 10 years. 80% are symptomatic by age 40, but it can even occur in older adults. The disease is characterized by a higher symptom burden than Brugada syndrome and long QT syndrome, at least as we know now. Unfortunately, there's a 30% mortality by age 40 if this is untreated, so some recommend lifelong therapy. CPVT is a disease of calcium homeostasis or calcium regulation. So let's look at the most common form of CPVT. This is due to an abnormality in something called a ryanodine receptor. This ryanodine receptor is a very large ion channel, and it sits on the membrane of the sarcoplasmic reticulum. This is a little organelle within the cell which really holds and releases calcium. So genes, normal genes, encode for the proteins of this channel, and they come together to make up this structure, which looks a little bit like a donut with the hole in the middle for calcium. Mutations in ryanodine can result in changes in this protein so that the channel is really unable to stay closed and calcium leaks out. Calcium is released when it shouldn't be, in diastole, and the cell doesn't like it, so it wants to get rid of it and exchanges it for sodium, both having a positive charge. Sodium, unfortunately, repolarizes the cell and creates these delayed after depolarization. So this is an action potential. I'm going to point it out to you because we're going to talk about it in the future. And it's like a little ECG from a single cell. And this is something that shouldn't be there, a delayed after depolarization. If you couple this with stress, you get the bidirectional ventricular tachycardia that occurs in CPVT. Keep in mind sodium, because it's important when we consider therapy. So cascade family screening is very important. It's important in a lot of channelopathies and is important in CPVT, where we should screen early because the disease manifests at such a young age. Now, it's fairly easy to screen when a genetic target exists, a little harder when one does not. But we do recommend the pre-symptomatic treatment of CPVT patients since the first symptom can in fact be sudden death. Back to that paper that we talked about where we looked at children with CPVT, and what we found was there was a delay in diagnosis. In this population, many patients had been symptomatic for 2 years before they were diagnosed. So for 2 years, they were exposed to risk. Once diagnosed, there was the near universal use of beta blockers. Beta blockers are the first line therapy for CPVT. We use the highest tolerable dose, and then we evaluate efficacy and compliance regularly by exercise testing. So in this study, despite the near universal use of beta blocker therapy, there were 5 deaths and 25% treatment failure. Was this non-compliance? Was this intolerance or subtherapeutic dosing? Or were people using the wrong beta blocker? Because not all beta blockers are equal. And this study looked at that. It looked at Nadolol and found it to be superior in CPVT. Nadolol is shown here compared to a more selective beta-1 beta blocker, such as atenolol. Nadolol is also superior because in older children, it can be given just once a day, so compliance is often better. If you look at these bar graphs and think about arrhythmia, Nadolol was superior. Green is good. These are patients without arrhythmias. Yellow are single extra beats, couplets, and non-sustained ventricular tachycardia. And you can see patients before therapy, really their symptom burden or the ectopy and tachycardia burden was almost as high as those on beta-1 selective beta blockers compared to the significant improvement with Nadolol. But what happens when even Nadolol is not enough? So events occur despite good beta blocker use. Beta blockers, Nadolol, fail to sufficiently suppress arrhythmias on exercise testing, or the patient is either non-compliant or intolerant. Well, more recently, flecainide has been added to the drug armamentarium for CPVT. It's proven effective in ryanodine and other types of long QT syndrome, CPVT, which we'll talk about, such as CASQ2 mutations, and even effective in gene-negative CPVT. It suppresses the delayed after depolarizations that we talked about. It directly targets the underlying arrhythmia mechanism. So it can inhibit spontaneous sarcoplasmic release of calcium in this, and is proven so in the CASQ2 model of CPVT. It can suppress the triggered beats, or these delayed after depolarizations, by blocking the sodium channel. Researchers looked at this at flecainide use in a CASQ2 model mouse of CPVT. And you can see here is the mouse. It's in sinus rhythm. It's given isoproterenol, which is an IV form of adrenaline. And you can see all the arrhythmias that occur after isoproterenol. Now that same mouse given flecainide and then isoproterenol continues to be in sinus rhythm. In human studies early on, they looked at the arrhythmia burden, shown here in purple, lots of purple being bad, in a little boy, age 12, with a CASQ2 type CPVT mutation. And you can see before flecainide with just a beta blocker and calcium channel blocker, a higher arrhythmia burden that decreased substantially with the addition of flecainide, and similar disease modeling in the 36-year-old CPVT patient with a ryanodine mutation. We looked at the use of flecainide and suppression of arrhythmias during exercise study. So this is the arrhythmia burden before flecainide and decreasing after flecainide, and found that flecainide and beta blockers were superior to beta blocker alone in reducing exercise-induced ventricular arrhythmias in CPVT patients. This is also a disease where we find that the left cardiac sympathetic denervation can be very effective. This videoscopic surgical procedure can interrupt the source of epinephrine release in the heart. This is a disease where ICDs can be particularly problematic. This is the pie graph showing all the different arrhythmias that can occur and are associated with shocks in the CPVT population. And probably this dark blue is the one you want to treat, and everything else is just wrong. So ICDs in this population have proven to be pro-arrhythmic. While 50% of these patients had appropriate shocks, another almost 50% had inappropriate shocks, shocks that were given when they shouldn't be. And unfortunately, this can result in an electrical storm. So repetitive ICD shocks, and this occurred in about a quarter of the patients. And about 30%, the ICD induced a more malignant arrhythmia. CPVT patients are young. They'll have to be exposed to this lifetime of ICD and its risk and complications. And some studies suggest that over the lifetime of a CPVT patient, 85% will experience an ICD-related complication. Shifting gears to talk about the most common channelopathy, long QT syndrome. This is a disease characterized by syncope, seizures, sudden death, and drowning, and increasingly we're identifying patients in the pre-symptomatic phase. It's a disease of the ion channel. These are channels that allow the flow of ions, potassium, sodium, calcium, in and out of cells. When they flow, they create electrical changes. So flowing in the cell, sodium causes the cell to get excited. And then the cell needs to relax. And part of that relaxation is getting potassium out of the cell. If the sodium channel is broken open or the potassium channels are broken closed, then the cell stays excited for a longer period of time, resulting in action potential, duration, prolongation, and that, if summed up on the ECG, is prolongation of the QT interval. If it gets long enough, it can actually generate these things. They're not delayed, but they're early after depolarizations. And if you have those at just the wrong time or just enough of them, it generates the signature rhythm of long QT syndrome, something called torsade de pointe. We now know that approximately 75% of long QT syndrome is gene positive, most of it long QT syndrome types 1, 2, and 3. Not all long QT syndrome is the same. The triggers can be very different. Long QT syndrome type 1, called that because it was the first one found, is a potassium channel loss of function mutation. So potassium has a hard time leaving the cell, resulting in QT prolongation. The triggers here are adrenaline, exercise, in particular swimming. This disease type, long QT1, is very effectively treated by beta blockers. Long QT2 is also a potassium channel mutation. It's just a different potassium channel. The triggers here are startle or sudden noises and women in the postpartum period. Beta blockers reduce risk, not quite as much as an LQT1, but are still effective. And more recent data from Dr. Ackerman's group is looking at the use or effective use of mexiletine for some high-risk LQT2 patients. And finally, long QT3 is different. It's a sodium channel gain of function mutation. Some sodium goes into the cell too much and for too long a time. The triggers here are bradycardia. Heart rate pauses, as shown here, where the heart rate's fairly stable, then there's a pause with the onset of ventricular fibrillation in this patient with long QT3. Sleep can also be problematic, and these patients can be treated with beta blockers or mexiletine. Again, just as in CPVT, not all beta blockers are equal. And in this study, they looked at the use of propranolol and nadolol versus metoprolol. These are the percentage of symptomatic patients. And so a bigger box is worse. And you can see metoprolol, far less effective than propranolol or nadolol. Mexiletine was also studied in patients with long QT syndrome type 3. This is the length of the QT interval, and you can see it in the specific patients decreasing with the use of mexiletine. And these are the burden of events before in red and after mexiletine use. This is a disease where lifestyle modifications can be helpful, things like avoiding QT prolongation, avoiding fever or treating it, avoiding hyperthermia. Sports are increasingly allowed, especially when there's appropriate counseling and gear. And we will caution patients with swimming and diving. And the final disease I'll talk about is Brugada syndrome. It's characterized by syncope and seizures again, but also agonal breathing at nighttime. This is a disease of older patients with a mean age of sudden cardiac death in Brugada syndrome at 41 years. This is the typical Brugada pattern on the electrocardiogram. And although this is a disease of older people, in the first publication by Pedro and Joseph Brugada, they had 8 patients and 3 were in fact children. Hormones and environmental factors can affect this population. Many events occur during times of increased vagal tone, such as sleep, bradycardia, slow heart rates, or fever, especially fever in children. In adults, there's a significant male over female predominance, and there are hormonal influences. So likely testosterone is playing a part here. The male predominance doesn't occur until children are over 16 years of age. This is just an example of a Brugada syndrome electrocardiogram in a little girl that I take care of when she was febrile. She had the classic changes of Brugada syndrome, which normalized when her fever went away. Unlike most of long QT syndrome, much of CPVT, Brugada syndrome is probably not going to, in most patients, end up being monogenic disease. So one gene causing the disease. It is in some, but not in every, and it's going to end up probably being a more polygenic or oligogenic disease. Treatment, I've put these two drugs up here because of the importance of fever control. Some places are using quinidine in this population. ICDs are also used, and obviously life-saving in some of these patients. And in the significant burden disease patients, there is some data, or are some data that are look at the use of ablation for Brugada syndrome. I'm going to shift gears a little bit and talk about more futuristic medicines. So Dr. Vincent created a very large pedigree of patients with long QT syndrome type 1. And in fact, this was the first type of long QT syndrome in the first family. This is a pedigree. Little squares represent dudes and little circles represent girls. A line through it means you've passed away. And if it's darkened, then you have the genetic disease. So this is a pedigree of many generations of long QT1 patients. I follow two. This is an asymptomatic little girl with a completely normal electrocardiogram, although she's gene positive. This is her first cousin who has this very abnormal electrocardiogram, even to the point of T-wave alternans, QT prolongation, who's experienced syncope. So this disease is characterized by a high variability of disease expression, even among family members who share the exact same ion channel mutation. They express the disease differently. So if you express the disease differently, perhaps you should be treated differently, and therapy should be more personalized. So how can this be accomplished? Well, more recently, by personalized, or what we call precision medicine. So what is precision medicine? It's combining an individual's genomic profile with clinical information to guide diagnosis, therapy, and intervention, or providing the right treatment to the right patient at the right dose and at the right time. This is not precision medicine. But what are the barriers to precision medicine implantation in inherited arrhythmias? Well, I think one of the big ones actually is variant adjudication. What this means is proving that the variant you've discovered in this patient is real and disease causing. Let's look at the variant adjudication timeline in long QT syndrome, because we have the most data here. Back in 1994, long QT syndrome was identified by linkage studies with many affected relatives, spanning many generations and a highly penetrant disease. Pathogenicity was based on the absence of this mutation in limited controls. And at that time, the controls were probably white people of European descent. Occasionally, these mutations were expressed in heterologous expression systems, so they were taken to a research lab, and using a zebrafish or an oocyte, they were proven to cause disease, but it didn't happen in all of them. Then in 2007, commercial and research labs began to identify disease-causing mutations and publish these long lists of mutations, many found in only a few cases. Fast forward, and we have the introduction of whole exome and whole genome sequencing. And in using this, we uncover remarkable genetic variation. So healthy individuals have common genetic variants that cannot be held responsible for disease. So now we are reappraising the veracity, or the truth, of minor long QT syndrome subtypes, and even demoting some mutations in the major subtypes. It's now thought that maybe as much as 10 to 20% of rare long QT syndrome variants were published prematurely and erroneously labeled as pathogenic. This is another problem. This is something you as families and you as physicians have probably had to deal with, the variant of unknown or uncertain significance. So maybe as much as 50% of rare variants cannot be classified unequivocally as pathogenic. and are labeled as this VUS. The care of inherited arrhythmia patients is plagued by this inconclusive genetic testing. This is a clinical dilemma because we cannot use these data for clinical decision making. So increasingly, researchers are using induced pluripotent stem cell-derived cardiomyocytes, heart muscle cells, and CRISPR-Cas9 technology for variant adjudication. So let's step through this. This is a little boy with clear long QT syndrome. He has an ECG that looks like long QT syndrome. You can take from him somatic cells, so just skin cells, blood cells, and grow them in a dish and make a big population of cells. Then using this technology invented by this man, Dr. Yamanaka, for which he won the Nobel Prize, you can add these pluripotent factors and drive these cells back to pluripotency. What that means is you drive them back to where they could become any type of cell. They could become a skin cell, they could become a heart muscle cell. Let's drive them forward to become a beating heart muscle cell. Now you can study that heart muscle cell in a dish, and you can look at the action potential, and you can see here, it's an action potential consistent with long QT syndrome. It's prolonged. And actually the arrhythmia is consistent with long QT syndrome. We're thoroughly after depolarizations and triggered beats. This is a disease model in a dish. More recently, and also Nobel Prize winning, came this technology looking at, which is CRISPR-Cas9. It's an efficient and simple gene editing tool. So let's see how these two technologies together can look at variant adjudication to prove a variant is real or not real. Again, we have our long QT patient. He's got an EKG that looks like long QT. We uncover some VUS in genetic testing. But we can recapitulate the disease. We can take his cells, make, using IPS technology, a cell that looks like long QT syndrome with action potential duration prolongation and a lot of irregularity in the cell's arrhythmia. Now we can use CRISPR-Cas9 technology to correct it. You can edit that VUS out of the cell, and proving it's not a VUS, you correct the disease. The action potential is now normal and the rhythm is now regular. There are problems with patient-derived iPS cells. They reflect a mixed population, although I think this is getting better. What we want are ventricular cells, but we might be getting atrial nodal cells or even fibroblasts. They probably represent a more early or fetal stage-like phenotype rather than the mature cardiomyocytes that we want. And unfortunately, it remains expensive and slow. More recently, researchers have used patient-independent iPS models to decipher whether a VUS is pathogenic or not. In this patient, who clearly has long QT syndrome, they identified this mutation in 639T in the CACNA1C, so calcium channel mutation, but they don't know if it's real. So you can use a control population. So this is not this patient. This is a normal person. They've created an iPS cell line looking at this patient's action potentials, and this person doesn't have long QT syndrome. Now you can take this mutation and edit it in to the normal person and see if the disease is manifest. And in fact, it is. And you can model normal against this now abnormal gene, proving that this mutation is in fact not a VUS, but real, likely pathogenic, prolonging repolarization, and importantly, can be used for targeted screening of family members. What are the advantages of this patient-independent iPS cell technology? You can demonstrate mutation causality. There are no patient-derived materials, thus this could be used in a post-mortem evaluation of a particular genetic variant. It's faster and less expensive because you don't have to create a new cell line. But unfortunately, the full genetic background of this patient is lost. So all the modifier genes are not there. So a negative result doesn't necessarily mean benign. So in conclusion, channelopathies can affect the young and the very young. Understanding ion channel biology can lead to a better understanding of these conditions and improve their treatment. These are inherited diseases with effective therapies, thus cascade screening and initiation of therapy can in fact be life-saving. Inheritance, unfortunately, may be more complex than it was originally thought. And precision medicine will in the future play a role in our understanding of these diseases and hopefully in their treatment. Thank you.
So that was fantastic, Dr. Etheridge. I enjoyed that tremendously. I think that was just a terrific, and I know everybody out there is clapping and they have questions for you. And I'm gonna not get to hear the question and answer session, Susan. I'm gonna jump over with the kids. But before I do, I just wanted to give an introduction to our next speaker who will come on after the question and answer session. But I wanted to introduce Prince. And Prince, I wish I could be here to hear you. But Dr. Prince Knackerl is a great friend. He's a really special man in our field. He's just an all-around super guy. Susan and I have known him for a long time now. He is like Susan, a pediatric heart rhythm specialist at Vanderbilt University. He's professor of pediatrics and cardiology. He has faculty appointments at the Vanderbilt Genetics Institute, as well as its Center for Arrhythmia Research and Therapeutics. And he's the director of their clinical translational research for the Division of Pediatric Cardiology. And as you saw from Dr. Etheridge's presentation, Prince conducted one of the really important studies in CPVT with the randomized trial that has really established flecainide as standard of care in the treatment of patients with CPVT, really as combination drug therapy. And so when it's Prince's time, he's going to give you a peek into the future. I think Susan kind of set it up beautifully with what that precision medicine future might look like. And he will be talking about future therapies for SADS conditions, a sneak peek into tomorrow. But you don't get Prince yet because it's question and answer time with Dr. Susan Etheridge. So Susan, enjoy the session and I'll see you a little bit later. And great job. I love that talk. Thanks, Susan.
Thank you, Michael.
So that's fabulous. I totally agree with that. I love that talk. And now, Susan, I have some questions from our attendees. So the first question has a couple of other people who added onto it, and that is it possible to reduce the side effects of beta blockers by taking other medication or changing your diet or whatever? And I think someone mentioned that their 7-year-old was severely depressed on Nadolol, and then he changed to atenolol, and now they think his anger and rage has soared. And someone else who's on Nadolol for 15 years and still has side effect struggles and needs to sometimes switch off generic. So
it's a very good question, and one that as a pediatric cardiologist and electrophysiologist, we struggle with all the time. I think that importantly, starting this medication at a very low dose and increasing the dose slowly if you're allowed, or if the patient is clinically stable, is very helpful. I luckily get to care for a bunch of patients who got to start their Nadolol or propranolol when they were tiny babies and have been on it their whole life. And interestingly, I think that population tolerates it better than if you get to start this medicine when you're an adult. I think that is harder. I don't know of any medicines in the background that make you tolerate beta blockers better. I do know that beta blockers can be problematic in terms of low blood sugar. And so I think that making sure that the patient is not exposed to periods of time when the blood sugar would be low, or having a rescue source of sugar at home would be very important in this population. I don't really advocate the use of atenolol. I try to stay away from that medication for long QT syndrome. There have been some case reports and data to suggest it is not as effective. I will use propranolol if a patient is struggling with Nadolol and vice versa. And if you are completely intolerant, and then I do often suggest patients be considered candidates for electrocardiac sympathetic denervation.
Great. So the next question is, what is the risk stratification involved to determine whether you, as a Brugada patient, need an ICD?
Ooh, very hard. Didn't go into that a ton because they're still really, really looking at that quite closely. Unfortunately, the genetics is so complicated in Brugada syndrome, unlike long QT, where you can kind of look at a gene mutation and say, is this a higher risk mutation, like a PORA mutation, et cetera. In Brugada syndrome, we're not that sophisticated. We do know that a portion of those patients have a sodium channel mutation, and this probably is a bigger risk group. Certainly syncope with the definitive Brugada ECG pattern is a risk, probably more so than a provoked ECG pattern. But unfortunately, this is a toughie, and we got to get it right because the therapy is fairly limited in this population, and really effective therapy is likely to be possibly quinidine, but more likely just a defibrillator. So maybe Prince will answer that question for us in his study or his talk.
That's great. Okay, next question. How can someone who fatigues easily on a full dose of Nadolol for long QT type 2 have peace of mind that they are protected if they lower their dosage for quality of life reasons? This person is asymptomatic.
Very good question. You could undergo an exercise study to look at what your peak heart rate is on your present dose of Nadolol and see if it's adequately controlling. You could potentially consider the bigger dose, but splitting the dose and taking it twice a day, divided twice a day, rather than just once a day. And again, this is a population where maybe a smaller dose of Nadolol and a left sympathetic denervation would be the answer.
That sounds great. And then this one, I'm not sure if, but I'm going to ask you, and you can say, well, it's not part of my talk, but is there any new research on the treatment and diagnosis of complete heart block?
Complete heart block?
Yes.
Well, I think we're still treating complete heart block with pacemakers when the time comes that someone needs a pacemaker. I think that there are people looking at a more biologic form of therapy for complete heart block. There are people looking at fetal pacing for complete heart block. But as far as new therapies, medications that improve it, biologic therapies that are available, no. I think, determining the timing of a pacemaker and pacemaker implantation are still all we have.
Great. Okay, and then I think this is the last question, at least that I have on the side here. And that is gene editing or modification being considered as a potential solution to Brugada syndrome long QT?
Very, very good question. And yes, and I think Prince will probably talk about this. I mean, gene therapy is something that is very intriguing, but we do not know all of the downstream consequences of gene editing and gene therapy in the clinical realm. And so we need to be very sophisticated and very smart. The disease needs to be significant. So when we have a good therapy for a disease that isn't gene editing, we should use the good therapy. If we have a very malignant disease, that's when gene editing and gene therapy will likely become important. Prince is going to talk about this.
Great. You know what? I think we have a few others as well. Now, based on current research, are ICDs not implanted in CPVT unless absolutely necessary?
Correct. If we can avoid it in this population, we do. We'll often use what I call and what Michael calls triple therapy in the symptomatic patient, beta blockers, flecainide, and a sympathetic denervation, trying very hard to avoid an ICD in this population because of all of the consequences of a lifetime of an ICD in a CPVT patient. Yes, there are patients with CPVT who need ICDs. I'm not saying that's true, but it hopefully will become a decreased utility in the future.
Great. And then what is the role of bradycardia pacing in long QT? Can atrial pacing be an arrhythmia prevention measure?
Yes, it can. It's really interesting. And in fact, a long time ago, we did a study looking at ICDs in long QT syndrome patients and looking at the decrease in disease burden. And interestingly, a number of patients got better from an ICD who never used the ICD. They only had atrial pacing. So it can regulate heart rate. It can prevent those pauses we talk about, which is how we induce ventricular tachycardia in the EP lab by having a tightly coupled beat followed by a pause. And so pacemakers alone can regulate that. It's always a difficult decision if you have a pretty symptomatic long QT patient. Do you just put in a pacemaker, or do you put in a pacemaker that, because all ICDs have pacemakers. So that is a complicated decision, but the question is excellent.
Great. Okay. I think we have all these questions answered. I'm sure we have lots more coming for the next session. So thank you very much, Susan. And we're going to show a couple of slides to the audience and chat while we change over to Dr. Ken and Carol. At least I'm assuming we're going to show. You need to go to the next session, as you guys probably already figured out. So a couple of reminders: if you didn't get a question answered, please feel free to ask it again, to ask it with Dr. Ackerman's session, which will be after Dr. Ken and Carol as well. And then you can always reach out to us if you still didn't get your question answered. We'd love to have you connect with your community. I know lots of people have already. There's community boards, there's the chat section. So please talk with all these folks from all over the world that are here and get to know each other. And then we will be having a karaoke party as part of our party playlist. So if you check out in the chat room, there'll be a link to the playlist. If you want to pick your songs, and if you want to sing with more than one person, feel free to do that. And then you can put that in the chat when we get to the party, so you can be on that list. And lastly, please help make our programming possible by donating at sads.org/donate. Thanks very much. And now just move to Dr. Ken and